so glad that you can join us. We are really excited for this session with Eric Cohen. He has been in oncology for over 20 years as an oncology nurse and has multiple settings, including patient medical oncology, bone marrow transplant, outpatient infusion, patient education, and has been a clinical nurse educator for the last 8 years. We are looking forward to this session tonight, is specifically focusing on HER2 positive breast cancer and ways to reduce your risk of recurrence. Welcome, Eric. Thanks so much for being with us this evening.
Thrilled for me to be here. I loved doing this last year. We had some great questions, and I look forward to answering questions at the end tonight. I'm going to share my screen. There we go. Okay, there we go. Hopefully you guys can all see that. So before I begin, this talk really is meant to educate you, to empower you, to give you confidence that you're asking the right questions of your healthcare team, and to really help you become a partner in your treatment. We know that patients that actually participate in their care have the best outcomes. It's very important today to really be a true partner in your care. And if it's difficult for you to be that person, then I would encourage you to always bring someone with you who can be that person. The information we're talking about today is as Carrie said, about HER2 positive breast cancer specifically. We'll talk about, well, before I get there, let me just give you the disclaimer for legal purposes. This presentation is for educational purposes only. It was developed by Puma Biotechnology. Any questions about specific treatments or your healthcare plan need to be discussed with your healthcare team and your physician. Okay, so these are the things we're going to talk about today. I'm going to give you an overview of HER2 positive breast cancer. We'll talk about recurrence, what it is, and what the risks of recurrence are. We'll talk about general treatment plans, and we'll talk about what your role is in reducing your risk. So let's start with the overview. In general, well, not in general, these are the facts of breast cancer overall, all breast cancer. 1 in 8 women in the United States develops invasive breast cancer, okay? Of those 1 in 8, about 15 to 20% will be diagnosed with HER2 positive breast cancer. Now, we have some great treatments for HER2 positive breast cancer, treatments that are targeted to the HER2 positive tumor cells. But even with our best treatments, the cancer may outsmart the medications and come back. Anyone with HER2 positive breast cancer, about a quarter of them will recur at some point. This is a disease of younger women in general. As you age, the likelihood of developing HER2 positive breast cancer goes down. So most of the time, if you're diagnosed with HER2 positive breast cancer, you're younger than 65 years old, okay? A lot of times women are in their 40s and 50s when they're diagnosed with HER2 positive breast cancer. The goal is cure. And for about 80% of women, 80 to 85% will be cured, but 15 to 20% will recur. That's why we're here tonight talking about that risk. There are some factors that may increase your risk of having a recurrence. These are at time of diagnosis. Having a larger tumor size puts you at higher risk. Having a greater number of lymph nodes that test positive for breast cancer. Being diagnosed at a higher stage. Being younger. Having a greater body mass index, of BMI, high BMI, and being a smoker. So let me just go back for 1 second. Some of these risks you have no control over. A couple of them you can control, right? Being a smoker, if there are any smokers in the audience, that I would really encourage you to get to take a smoking cessation class. Try to get rid of that habit. It's not good for this particular kind of cancer. It's not good for your health in general. And also having a greater body mass index. So if you are if you do have a high BMI, then doing things to reduce that BMI would also be really helpful to reducing your risk. So I keep talking about HER2 positive breast cancer. What exactly is HER2? What does that mean? Well, our bodies have a gene that's called the HER2 gene. And normally, the HER2 gene makes a receptor that sits on the outside of a cancer cell. So if you look on the right, what you're seeing is a receptor. It's on the outside of the cell, but it also, you can see that it crosses the cell membrane, and part of it is on the inside of the cell, okay? This HER2 receptor, when a HER2 protein binds to that receptor, it turns the cell on and tells it to grow and divide. This is normal. This is normal physiology. This is happening all the time, okay? But in HER2 positive breast cancer, you have a much larger number of those HER2 receptors. So normally, you may have, and I'm going to make up these numbers, but normally you may have something like 1,000 receptors, okay, on the outside of your cell. If you're diagnosed with HER2 positive breast cancer, that means that your cells have something like 1 million, right, or more of these receptors. That's the difference. It's that you overexpress these HER2 receptors. And because of that, the cells just continue to grow and divide, and it's not controllable, and that's what cancer is. Now, the good news is there are specific treatments that target that HER2 receptor, and we're going to talk more about that. But all of those treatments are designed to help reduce the risk of recurrence. How do you know you have HER2 positive breast cancer? So this comes down to your pathology report and to the most important player on your healthcare team who you will never meet. That is your pathologist. In general, you never see the pathologist, but they really are the most important person because they're the ones that determine exactly what kind of cancer you have, and that determines what treatment you will get. So it all starts with the pathologist. And there are two things that the pathologist that are looking at that we're going to talk about tonight. One is the HER2 status, right? That tells you how many of those receptors you have on the outside of your cell. You'll either be diagnosed, and your pathology report will say you're HER2 positive, you're HER2 negative, or it may say that you're borderline initially. And if it says you're borderline, that just means that the sample they got when they did the biopsy, it looked about even as to how many receptors there were, okay? And so they'll do additional tests to find out if you're actually HER2 positive. The other thing that is important for this is your hormone receptor status. So this is where things get a little confusing because there's HER2 and there's HR. HR is your hormone receptors. In the old days, we used to refer to them as estrogen and progesterone receptors. Today, we just say hormone receptors, okay? So you'll either be hormone receptor positive, meaning you're ER/PR positive, or you're hormone receptor negative. This is also going to be an important part of your treatment plan in determining what medicines you get to treat your cancer. If you're hormone receptor positive, this means that one of the drivers of your cancer is estrogen and progesterone. Knowing what the specifics are of your cancer is really important. So the next thing is, if we were together in a room, and hopefully one day we will be able to do this live, we can have more of these discussions. But what I want you to reflect on tonight is, do you know what your HER2 status is? And do you know what your hormone receptor status is? And if not, I would encourage you to go back and take a look. So let's talk about recurrence. What is recurrence? There are several kinds of recurrence, but recurrence means that your cancer has returned after the initial treatment. The two kinds are, it can either be a local or regional recurrence, which means that when it returns, it's near the original spot, wherever the original tumor was. It's in close proximity. There can also be metastatic recurrence, and what that means is that the cancer has spread to another part of the body, such as the bones, the lungs, the brain, or the liver. So metastatic recurrence is also known as stage 4 disease. Okay? You may have heard about it that way. Now, you're all here tonight, so my guess is you kind of are aligned with this. This was a study that was done by breastcancer.org in 2017. It was really a survey, and they asked HER2 positive breast cancer patients a bunch of questions. And what came out of that survey was that 93% of women with HER2 positive breast cancer stated that they were concerned about the possibility of recurrence. And 78% said that it was their greatest concern. That was really the main thing that they were concerned about. This is very common. And if you go to support groups, you'll hear this. Women know about this. If you're doing any research at all, you've probably seen this. The idea that you might recur. Remember that 80 to 85% of you will not recur and do really well. 20 to 25% may recur. The difficulty here is that we don't know who's going to be in the 80% group and who's going to be in the 20% group, at least not yet. Hopefully one day there will be a way to test and know if you're truly in that high risk category. So why does this happen? Why does the cancer return? Well, the way these treatments work for HER2 positive breast cancer. Now, remember, I showed you that picture of the HER2 receptor, and that it's on the outside of the cell, but that it crosses into the inside of the cell. So the treatments are designed to block that HER2 receptor by doing something on the outside of the cell or blocking the inside of the cell. If you block one pathway, then what happens, or what can happen over time, is that the cancer learns that it can use the other pathway. So if you're blocking the outside of the cell, then the tumor can learn to use the inside of the cell. As I said earlier, there are great treatments for HER2 positive breast cancer. There are these drugs that are targeted specifically to that receptor on the outside of the cell. And by using those therapies, we've improved survival rates by more than 30%. Now, I've actually been an oncology nurse longer than Carrie said. I hate to admit it. I like the sound of 20 years, but it's actually been longer than that. I remember the days when we didn't have that therapy. It's called Herceptin, and we did not have Herceptin when I was started in oncology. And when it came out, it was like a miracle, because all of these women started living that were not living before. So it has been really effective. However, it's not 100% cure rate, right? And that's what the number that we want to get to. So even with the newest therapies, the newest monoclonal antibodies, there's still a risk that you could recur. But there are things you can do to reduce that risk, and we'll talk about that. So this is what treatment plans look like. And everybody's is a little different, but this is a general treatment plan. And the way it works is that depending on the size of your tumor when you're diagnosed, you may have some treatment before surgery, and that we call neoadjuvant therapy. So if you get neoadjuvant therapy, we're going to be giving you some targeted therapy or chemotherapy with the goal of reducing that tumor size as small as possible, so that the surgeon, when the surgeon comes in, can take as much out as humanly possible. So there's neoadjuvant treatment before surgery. If you have, not everybody gets this, but if you have a larger tumor, you will probably get that. Then you would have surgery. Again, the goal of surgery is to remove whatever we can see. Any lymph nodes that might be involved, any tumor that might be in there, we get rid of as much of it as possible. After, and hopefully all of it. After surgery, there's adjuvant therapy. That is where you see the chemotherapy, radiation, endocrine therapy, and the targeted therapies. That's all in the adjuvant therapy setting. And that, the goal of that is to eliminate any of the cells that the surgeon couldn't see, right? Any of those microscopic cells that the surgeons can't see with their eyes. That's what the adjuvant therapy is designed to do, is to kill those cells, which reduces the risk of recurrence. Then after adjuvant therapy, there's also something now called extended adjuvant therapy. It works differently. We'll talk about that. And the goal is, again, to even further reduce the risk of recurrence. So different therapies target the HER2 protein in different ways. What is most common is that you will target the HER2 receptor on the outside of the cell with these large molecules that we call monoclonal antibodies. You've heard of one of them, I guarantee it, it's called Herceptin. So you will get, in your adjuvant treatment, you will get Herceptin. You may get something called Perjeta. You may get something called Kadcyla. These are all monoclonal antibodies, and they're all binding to that HER2 receptor on the outside of the cell. But like I said, the tumor in some cases outsmarts that therapy over time and starts using the inside of the cell. So just reflect here for a second. Are you currently on adjuvant therapy, or have you just recently finished adjuvant therapy with a trastuzumab-based regimen? That would be the ones I mentioned, Herceptin, Perjeta, or Kadcyla. And has your doctor talked to you about additional ways to help further reduce your risk of recurrence even after your adjuvant therapy? So let's talk about your role in reducing your risk. It's really, really important for you to be active, an active participant in your treatment. You really are the ones that drive treatment. The doctor may guide you and choose the right medicines, but it's your health. You are the driver, and so you need to be actively participating in what that plan is going to be. That's why you're here tonight, because you're learning the right questions to ask to be that active participant. You want to make sure that you're always talking with your healthcare team about any concerns that you might have that might come up during treatment. How to manage potential side effects. Anytime you get a side effect, you don't want to hide from that. I know that there are patients out there that think if they report a side effect, the doctor will stop the medicine, and they're afraid that they won't have something else. That's not true, right? The doctor, your healthcare team, your nurses, your nurse practitioner, PA, they're all in it with you, and they want to help mitigate those side effects. And so you need to report them as soon as you feel them so that they can do something about it to help keep you on the medicine. If you ever have questions about nutrition or diet, one of the things I didn't mention in the beginning of this, we can talk about this later, is that I also have a background in nutrition and integrative health. That's what my master's degree is in. Exercise is really, really important. So being active, it doesn't mean that you have to do a competition, that you have to run a marathon or be a weightlifter. It does mean that you have to be you have to have an active lifestyle. And that can be walking, can be gardening, it can be doing things around the house. But being active is really, really important. And we know that the more active you are, the better your outcomes, the longer you live, the better you're able to deal with chemotherapy and all of those side effects. And then also asking your healthcare team about what else is out there? What else can I do to reduce my risk of recurrence? Because things are always changing. I think that's the point of that. And then once they prescribe something to you, once they say this is the plan, you really want to stick to the plan. If you don't really understand the plan, ask more questions. If you're not sure about the plan, ask more questions. Get your questions answered and then stick to it. Once you've decided to go with it, stick to it, right? It's not a good strategy. And the reason I bring this up is because today there are a lot of oral chemotherapies. And my feeling is that patients in general think that the important drugs are the ones that they're getting in the office, the ones that the nurse is infusing, through an IV, that those are the important ones, and the orals are not so important, more like chronic medication. You can take it, you cannot take it. That is absolutely not true. We have to be really good about, if they're prescribed, that you take it exactly as it's prescribed. Just like an antibiotic, you have to finish that antibiotic. It's the same thing if you get an oral chemotherapy. You really want to stay on it. So yeah, that's what I'll say about that. Here are some questions for you to think about. I'll leave this slide up for a minute. You can write it down, but I'll also tell you at the end, there are some resources that you can get and print off the internet. That will help you as well. But some good questions to start with. What are my risk factors for recurrence? Asking your doctor about your specific risk factors. Given my age, cancer stage, tumor size, lymph node involvement, and response to treatment, what is the risk that my HER2 positive breast cancer will recur? What else can I do to reduce my risk of recurrence? What other medications can I take to also reduce the risk of recurrence? Okay. You don't really have to write all those down because I'm going to give you a resource right here on this slide. You're all welcome to go to reducerecurrence.com. You can print out these resources. There is a recurrence discussion guide. So it's a really nice guide for you to take in to your doctor, to your healthcare team, and ask them the questions, and you can write down the answers right in the discussion guide. And then there's also a treatment planning guide that can be very helpful as well. So knowing what your options are and participating in the development of your treatment plan is really, really important. This is what will make you feel more confident that you're doing everything that you can do to reduce your risk of recurrence. The last thing I'll say is that support groups, like the ones that you have at Carolina Breast Friends at the Pink House, are really, really important. There's a lot of wisdom to be gained in other people's experiences. So meeting together, sharing your experiences is really, really also a very important thing when you are diagnosed with cancer. And that is the end of the official presentation, and I'm happy to start taking questions.
Thank you, Eric. We appreciate your time and this presentation. And on behalf of Carolina Breast Friends, we appreciate you and look forward to working with you again. Thank you.
Thank you.